Hey, how's it going, guys? This is Dr. David Dionso of SHARC Doc Talk with
PT Nandi.
And today we are going to talk about some fun stuff.
Fun
stuff with fear.
Fear factor.
Yeah. Oh, well, that could be a little fun segue there.
Fear in PT. Yeah.
100%.
Fear and recovery. Yeah.
That is more common than we think.
Yeah,
it is.
definitely.
But before we jump down that fun little rabbit hole of fear, pain, surgery, all that jazz, right? How was your week?
How was my week? It was a good week, fairly long, but nothing too unusual.
Mm-hmm.
Did have some good, I guess. Wow, can't talk.
English is hard.
Yeah, exactly. Talking is easy, isn't it? Good milestones, I would say, with some patients who are getting better, which is nice always, especially those kind of complex patients where they come in and they're kind of shifted and radiating pain down their leg and things like that. Have a patient now who is a mother with 2 small children, 5 and 2, and literally walked in and could not bend over, it was like shifted side.
The mom or the kids?
The mom.
Okay.
Now she's back to doing all of her Pilates tapes at home.
Oh, nice.
and being able to lift and carry her children. So that's really was a good milestone for me and for us to kind of get through all of that and see her get back into her normal stuff. And then another patient who had just recently got a cortisone shot for a bursa for her greater trochanteric bursitis.
To kind of explain some of what a bursa is, basically it's like a little fat pad. To oversimplify it, a little fat pad at specific parts of tendons or like where tendons would touch bone or like tissue would touch bone.
It's a cushioner, like you said, to cushion the junction between a tendon. And most commonly we have them at bony prominences. We have them in our sit bones or at our ischial tuberosities where our hamstring's attached to our pelvis, and then we have them on the side at that hip bone kind of poking out the side in your hip.
A couple in the elbow, a couple in the shoulder. So yeah, they look like little gummies if you look at them.
Nice.
So yeah, they just add a little bit more cushion for things to move around it.
But hers was inflamed on her left side. We'd worked and tried to get her muscles around there to release and relax a little bit. But I was like, cortisone shot might actually help. Don't really like to kind of push those too much. And she went and got it done, and that was like perfect.
Oh yeah.
Took like 90% of that pain away, and then it kind of revealed the kind of underlying lumbar condition that she kind of just chronically deals with. So
yeah, sometimes like that can be necessary, right? It's like I'm on board with you. Like we don't always have to go get the cortisone shot.
I don't feel like it's my first line of defense. I feel like, and I had an interesting discussion with with Dr. Robertson about that too. And I was like, well, what is your opinion about that? Because I watched him do a PRP shot, and that was really cool.
Oh, that's cool. He let you in?
Yeah, that was neat. It was neat.
I'm gonna have to see if I can.
Dude, you gotta get in on that. It's cool. I watched it as it came out of the centrifuge. She separated it and then injected it. I mean, the injection part in and of itself is pretty.
It's an injection.
Yeah, it's pretty basic and isn't like bells and whistles, but the whole separation aspect was pretty cool.
Yeah.
So that was kind of neat. And then so I asked him about it. I was like, well, so what's your opinion about a cortisone shot? And he said he likes to do absolutely everything because of the instability and the effect on the connective tissue that cortisone has, especially in things like hands and feet, because I know some docs will not do them in feet at all just because of there's no muscle holding everything together. It's all thin. And so but it really helped her. And then again, like I said, she had a little bit of irritation in her lumbar spine, and we kind of cleared that up, and that made a ton better too. So
yeah, I think my thought process on that. I'm not opposed to the cortisone shot. I'm not opposed to like PRP. I'm not opposed to like any of the things that are supposed to help deal with pain. I just don't like them as your first.
Yeah, no, I agree.
It should be your first line of defense.
Let's try to get everything.
Because I mean, at the end of the day, like some of our philosophies are like, if we get you out of your pain first, then we can kind of work on all the other things while that's happening, right? If you're in so much pain where we just can't even work on just basic mechanics that led to that pain, then we're kind of at this impasse. So sometimes a cortisone shot might be of benefit, or, you know, if we can't, I legally can't technically recommend that you take Advil, right? But if you chose to take Advil and that decreased some of your pain, and then we are able to get through your exercises, maybe we start there, right?
Yeah, that's like the precursor to know if ice is helping and if Advil are helping. Those anti-inflammatory agents can kind of lead that direction towards it. If we can't get everything released, everything stronger, things like that.
100%. Totally. So with those things, it's very important to kind of see if we can obviously get the root of all the problems, like if it's a movement problem, if it's like a true nerve problem. But if we can't even just get you like off the table without pain, then we might have to do something else, right? Obviously, we're going to try everything our best to not have to do like a cortisone shot or anything along that type of nature that's a little bit more invasive. We'll do what we can do, but we also know our limits, and I think that's what's fun about us is I have an ego like everyone does, but I have not enough to say I can 100% do this when I know I can't.
Right.
Or if I can't do it, right, I will do all the research that I can do to see where is the next best step, or if it's something that I can handle. So needless to say, I'm always just trying to get you the best thing that I possibly can get you, whether that's me, whether it's Nandi, or whether that's like someone like Dr. Robertson or Dr. Goswami, then we'll do all that stuff.
Yeah, that's
we work
nice.
Together for the benefit of you.
Yeah, for sure.
Well, that's a fun little
that
week
was good.
together.
Yeah, it was good.
Yeah.
It was good. Yeah. What about you? How was your week?
This week, lots of learning with Doc T. I have taken up more responsibility in the office just how the nature of things go. So it's a lot of reviewing of cases and things like that with patients that he normally sees and he can't see all the time now anymore. Right. So sometimes I have to take over the case. I'm like, okay, I don't know what your brain was saying on this one. I just want to know. So that was a lot of things.
Oh, nice.
This last week.
Kind of an inadvertent brain picking of.
Yeah. Basically, it's basically that. I would even say it was like trying to drink out of a fire hose.
Sure.
As in, yes, I know a lot of what Doc T's going to do, but sometimes there's I just one. Like I have no idea what you're going to do with this case, right? We had a fun little case here that popped up into the office. I think she was like a 10, 11, 12-year-old girl, tennis, dealing with issues of like hypermobility, with like knee pain and things like that, right? So much so that she just got fired from her last PT spot where they just kicked her out. It's like, hey, it's either surgery or just don't come back. Right?
Yeah.
Which, can be very disheartening news to a patient.
It was her knee?
Knee.
Okay.
Yeah. So it came to us where we started that eval, but there was a couple things where I was like, this is interesting. Meaning that there wasn't necessarily anything inherently wrong with her. Meaning that she could move, she could do whatever she needed to do, but there was some levels of control and stability that she was lacking because she's so hypermobile.
Right.
So she has a history of being a dancer, and then a history of playing tennis, and then all of a sudden one day, kneecap subluxed. So it's not necessarily like a full dislocation where it just comes out to the side or off to the middle. It just moves in a really weird way out and comes back in. So she has had some of that before. So we just had her do some basic motions. We noticed the muscles that we want to work aren't working the way that they're supposed to work. So for example, right, this didn't happen with her just because I don't want to give off too much information. I'm going to go do the example with my upper body. She was dealing with a lower body complaint. But for example, we would ask her to like, if we were to ask her to bend the wrist and keep the elbow straight, her whole idea was to kind of do this.
Nice.
So we checked neuros. Everything was pretty fine, just to be sure, right?
Sure.
Like if it's something else, let's make sure. But it was just how her body would translate motion because it's finding stability somewhere else. So we led her through some like functional exercises to kind of see where she was at and where she was supposed to be feeling. Did not feel it there. I was like, okay, we might have something to work with here. So it's going to be a fun little interesting case to dive down into. I'm excited to see that one.
Nice.
Just because it's definitely one of those ones, if that comes to you as a student, you do all your orthos and everything like that, you're like, technically fine.
Yeah.
But
I don't see anything.
Yeah. That was one of those ones, if you gave this to me like 3 years ago, I'd be like, let me take notes, and then run out to doc team and be like, I have no idea what I'm doing. But yeah, it's gonna be a fun one on that one. So yeah, obviously don't want to give off too much information because I might feel like
Right. Yeah.
give out the accidental identity of this person. So we're not doing that. We're not doing that here today. But yeah, that also led me to kind of what you brought up, because we saw some ideas of like just fear.
Yeah.
In that entire thing, just because like for her, that type of patient, it's not a true pain, but it's like, what if this happens again?
What if it happens again? What if I don't
worse?
know? She sounds like that you were the kind of last resort.
Yeah.
What if this doesn't work? Already, she probably has some apprehension with being fired by her previous PT.
Yeah, which is a very real thing.
Right.
And even with your patients that you've been seeing, the mom, right? What if she can't play with her kids? Like,
Yeah.
those are big questions.
Yeah,
Like,
and my patient who had the bursitis and had the cortisone shot, she told me she was like up almost all night the night before the shot thinking, oh, it's going to be painful. How am I going to deal with that pain? Am I going to be able to walk on my leg? How is it going to feel? And she literally felt no pain during the shot. She was like 90% better after the shot. And so, I mean, it's definitely a real concept because it's that psychosocial aspect of rehab that we don't necessarily we learn about it in school, but we look so gross motorly at the patient that we don't necessarily, it's not something that is presented to us by them physically.
100%.
Right.
I do think that not to bash any school, but I feel like schools don't necessarily talk about that enough. Because we often look at the body as in like this part works with this part.
Right.
So this knee is supposed to slide on top of that femur, and then you do X, Y,
Well,
and
and
Z.
it's the whole
true.
separation, like somatically, of our mind-body connection, right?
Yeah.
I mean,
We're not robots.
no, and by no means, and that whole perception of our physical aspect can get lost in rehab, and if we don't address that, it can really make a huge difference. That's for sure.
And I'll say this first. I don't think fear is a bad thing. It's just being controlled by that fear to do your rehab is kind of something that we have to address, right? When we talk about pain, I often, like you mentioned, talking about biopsychosocial somatic things, right? Oftentimes I think of fear, especially if it's fear of just basic motions of like, hey, let's go grab this protein container. Let's go write this note or book or type or just drive. That fear can actually be what I consider a multiplier of pain. So maybe that pain's not too bad, but you are scared to go, for example, just say drive a car because you've gotten in a car accident and you have pain with that. If you're too scared to drive, your body might actually just focus in on that pain this entire time and make it worse than it actually is. Not saying that the pain isn't there,
Right.
but you just made it worse.
Yeah, I agree. I think the other thing too is that there is the thing I've learned a lot is that we teach a lot of like pain-free motion. So they, like you said, kind of reaching for something. If they're reaching for that and they can readjust their posture so that there is the ability for them to still reach for it without pain, that can help take away some of that fear or that idea of apprehension with reaching or anything. And so sometimes when I'm working with a patient who has some low back pain and we tell them, okay, this is what a posterior pelvic tilt is, and that's going to help you lead into a bridge because we want you to it'll help you kind of stabilize. And they're like, oh, but I can't do that because it's too painful.
No.
And then I say, okay, well then let's kind of look at how far you can go through that, or even the most simplest thing like sitting down.
Yeah.
You know, how do I deal with getting through that range of motion without understanding that it's always going to be painful?
100%. Yeah, like a lot of times our job with the rehab is actually just to give them permission to move, right?
Yeah.
So a lot of times there'll be a plank of some sort to have some stability because right now for you, it might hurt to just move.
Yeah.
So maybe we just make it stable. Or the person with hypermobility, we need some stability going on, right?
Yeah.
And then maybe later down the road, right, when we pass or your natural time of healing, Like, yeah, well, we might just have to work at your end range and be good there. So this idea of fear with pain is a really big limiting factor that I usually like to address my first visit. I'm like, hey, I know you're scared right now.
Yeah.
Doesn't mean it's always going to be this way.
Yeah.
Especially with like a more traumatic injury, whether a car accident or like a basketball player that sprained their ankle, right? Especially if it's their first sprained ankle. I remember this wasn't a basketball player, but a friend of mine, she stepped off a curb, first time she ever like sprained her ankle, concerned that the pain was still there like 2-3 days later. And that I chuckled to myself because I thought about all the times I played basketball and was like, yeah, that sucker right there is going to be there for a couple weeks. So let's learn how to deal with some stuff. But even in those type of rehabs, that ankle rehab, your basics in the beginning are just seeing if we can get you moving without much pain. Sometimes there will be pain. We're not afraid of it.
Right.
But we can't let you just be stiff the entire time.
And I think what can help too in that whole concept of getting over the fear, and not that we're telling them to just get over it.
We aren't just doing that.
But to help them understand that there is a pain-free range, and we show them, oh, look, you can move through this degree of range where you have no pain, and that's where your foundation will start to build the strength. And once you get through that, then your mind and your body will understand, oh, I've got some range I can move through. Now I can build on that.
100%.
And I think that a lot of what I try to help them understand is that we're trying to stimulate the nervous system as well, to not think that you only have to have pain to move and get stronger.
100%.
Because then that doesn't work. The nervous system will always fight back.
Yeah, and it'll always pattern like pain with motion.
Yes.
And that's not what we want to do.
No, because there's definitely ranges of motion that you can go through that is always going to be pain free.
Oh yeah. There's also the concept of like, that purpose of pain is just to hold you back from hurting it more. So we're not disagreeing that, if you have fear, taking a step right now, totally understand.
Yeah.
Like when my knee was gone, right? When you assessed it that second time, right? Yeah, I tried taking a step. That first step could not do, right? So that next step that I tried taking by myself, there was definitely when I was trying to get out of bed to put weight on the knee, I was scared. Like, I don't know what this body's going to do. Yeah. But with that too, the funny part when that happens is that a lot of times that fear and that pain might inhibit the quad from working to protect the knee because it doesn't want to move, right? But guess what's one of the first things that we do with like a knee problem?
Yeah, we
terminal knee extension.
Activate that quad, man.
Get that quad going. So it's not that we disregard it. It's just we have to pattern it correctly in a pain-free way. Terminal knee extensions should not hurt, right? If they hurt, then maybe we start somewhere else.
Yeah.
But it's one of the most basic motions to do, and I remember doing that all day. My first, the first day after the injury, but then the second day or the second, third day when you saw me again, was moving much better.
Yeah,
right?
Most definitely.
So with fear of motion, it's a very real thing, but we have to see where you can move and work within that range as best as we can.
No, I think so. I think that and giving them the permission to understand that fear is valid.
Yeah, 100%.
Was, I think, the biggest thing that really helped me supplement kind of how I dealt with that aspect when it came up in any of my patients' rehab. Any of their plan of care was always kind of supplemented with, okay, look, this is where you were. This injury was this and that severity. Yeah. And as you get stronger, you'll start to understand that you're teaching not only the muscle to get stronger, but really the nervous system to understand that it can
do everything. Yeah.
It can bounce back and get back to that connection, and then you'll be stronger and you'll be back to doing what you were doing before.
100%. Yeah, especially I go over that, like just give them like the permission to be angry, to be totally distraught about what happened.
Yeah, go through that whole recovery cycle.
If you need 5 minutes just to let it all out, I'll just be silent and you can talk, right? I get it. In some ways, we're not licensed therapists in that manner.
No, but I mean, it's not just
part of our job.
It's not just called physical.
Yeah,
it is called physical
therapy. You can go to him, right?
Because chiropractic is it's not in that name, but still, it's a 100%. Form of rehab. And there's that we take psychology classes in school for a reason. I used to after taking them, I was like, well, why are we doing that?
Yeah, and then you see your first patient,
and then you're like, oh yeah, okay, that makes sense.
Yeah, 100%.
And that's why doctors can go to medical school with a psychology degree.
Yeah, yeah. So there's that big overlap between everything.
Yeah,
so
that's interesting.
I think part of the reason why that helps too is like we have our longer visits.
Yeah.
Sometimes for that, like,
Yeah, right.
as in like, hey, if you just need to let out the frustration that you
Yeah.
could not walk up these stairs right now without pain, I get that. Just let it out.
And I think too, like your
Yeah.
experience of going through what you went through with your knee, me going through what I went through with my total hip replacement.
Yeah.
I mean, there's always that level, that concept of fear creeping in,
Yeah.
that this may never be the same again.
100%. That it's a very real idea that passes your brain.
Yeah.
Right? I think oftentimes, like, the biggest predictor, like, of what we said in previous podcasts, the biggest predictor of injury is previous injury. Mm-hmm. And then your brain goes to like, okay, what if I can do this, or this, right?
Definitely.
Very true, right? And oftentimes I like to reframe my thought process and then even the patient's thought process of like, there may be some things that we just can't do anymore, right? Like for me, since I didn't have a surgical repair on my knee, I'm not going to play basketball the way that I did prior. Not because I'm scared to go up. It's more of like, I know the consequences that could happen with my knee right now because
Right.
it just might fall off at this point.
And that was actually a big thing with me too, with my hip replacement, was running. Like I'm totally fine if I don't run again.
Yeah.
And there's times like I can run across the street.
Yeah, but like long distance, maybe not.
Like I'm not training for any marathons or anything like that.
Yeah, and then instead of just focusing on that, right?
Yeah.
I usually just have to reframe. It's like, look at the stuff that you can do again, right?
Absolutely.
When someone throws out their back and they can barely get out of bed and they can barely just like move and they're like bent over walking in, and then you go to just standing up, but you say, oh, I can't lift right now. Like, dude, you barely walked in through that door right now, and now you're walking. Let's focus on that right now. Or my favorite, right? Because this is commonly uncommon, where it's like, I came in 4 weeks ago, hurt my back. I'm not as strong as I want to be. Pain is there, but only like if I lift heavy. I'm like, okay, hold on. You chronically were dealing with low back pain walking into this office, right? Now you barely feel this pain, like barely. But until you hit something really heavy for you, then that's a win.
Yeah, totally.
Like you could go use the restroom, not have any problems coming back up off the toilet, or like even just bending over to wash your hands in the sink. Those are huge things. Those are milestones, in my opinion. I get excited about that. You get excited about that because now we're returning you to life.
Yeah.
Now then all the fun, hard stuff to rehab, which is fun in my brain, is now on the table.
Yep.
So those things is where if we start to focus on the one thing that we can't do, we kind of miss the miracle of what just happened.
Definitely overrides the stuff, the small little victories and the little normal things that you can do now because you are pain free with that functional stuff.
Yeah. And then at that point too, when we talk about fear, sometimes it's the fear of the pain after, we'll just say a year, that actually is what causes the pain sometimes. I'm not saying all the time, but sometimes it does, especially with your chronic pain patients.
Yeah, totally.
Like I know for me, like squatting really heavy on this knee, sometimes I get a little hesitant, right? But the fun part is all the weight right before the heavy one is fine.
Yeah.
And all of a sudden I start thinking, what could happen? Then the body's like, oh yeah, what could happen?
Yeah, what could happen? Let's see.
And then the pain starts to come back, and then I realize, oh, I'm just scared. Just give me a second.
Yeah.
Give me an extra 30 seconds, rest coach, and then we'll keep going.
Just let me breathe.
So all this to say, pain is very real. We recognize it, and we want you to feel it, but we don't want you to stay there.
No.
Yeah.
No, and also be able to recognize that the fear that you have with pain and the recovery through it is real, as real as you believe it to be.
Yeah.
But it's not going to be there forever, and
100%.
it's another step. It's like, getting through 3 sets of 15 squats at 45 pounds and then getting stronger, so now you can do it with 75 pounds.
Yeah.
It's just another step, and it's something that will come along on a natural process
100%.
through the path of your recovery.
Yeah, and it's also just recognizing, like, part of fear is, like, you don't know right, what's going to happen.
The unknown, for sure.
And especially with rehab and, like, pain, it's very much, there's a lot of stuff that you don't know, right? Because you're not going to feel fantastic right after your first rehab exercise. It's a lot of times you don't feel good.
No, I remember being sore for almost a month after my total hip. Yeah. And I was like, oh, yeah, this is different. This is like I'm getting in shape again, and now my whole body just is
So,
sore.
yeah, 100%. So one of my things with combating that fear is just like, no, just educating them on like the natural history of an injury.
Yeah.
Right? So like an ankle sprain, grade 2, where it's not completely torn, but there's definitely a tear. Yeah, I'm expecting like 4 to 6 weeks.
Yeah.
Maybe 8, like if you're not active at all. Like it's a possibility for sure.
Oh yeah.
But by that time we should be okay. And understanding that there's an end date to all of this is usually pretty, at least for me, liberating to understand that we're going to be okay.
Yeah.
Yeah. Do you go over that with your patients at all, like in terms of timelines of pain?
I go over the amount of time it takes for tissue to heal and get stronger.
Oh, yeah.
Like bone healing and stuff. We have a timeline for that. We've got timeline for how long it takes for muscles to get stronger. I think the biggest thing that I think helps patients that I've seen is that the understanding of how long it takes for a muscle to get stronger, but the fact that a muscle we grade the muscle from 0 to 5, and that at 3+, you're not going to go from 3+ to 5 normally in that 4 to 6 week period.
Yeah, you're probably getting just a 3+ at that point, 3+ to 4.
Yeah, and then you're going to go maybe 4- so to 4, and then go along that increment. So you have to kind of compound that 4 to 6 week window to get to that 5 out of 5 strength. And I think when they kind of understand that, they kind of realize, oh, so it's going to take me a while.
Yeah, 100%.
You know, and now I understand how I got to be patient versus, oh, how come in 3 weeks or how come in 6 weeks I'm not back to 100%?
Yeah.
Because the body doesn't work that way.
No, 100%. One thing that I've also started to do too, right, is try not to overthink the rehab, and this is what I mean, right? Obviously, I'm going to start with your basics, make sure we're all good first. But let's say it's someone that threw their back out in a deadlift, right?
Yeah.
And I could get really specific on like at what muscle is firing at which angle, X, Y, and Z. Do we want more hip drive? Do we want more quad locking on the extension? Whatever, right? But at the end of the day, if you want to deadlift, we're gonna have you deadlift sometime in this office, right?
Yeah.
In front of us, so we make sure everything that we worked on is fine, right? Rather than just saying, yeah, we go to the deadlift 500 pounds.
Go ahead. Go back to the gym and start your deadlift again. Yeah,
but that's going to be a part of your rehab. So the stuff that we hurt ourselves on is something that you are going to have to face in here.
Yeah.
If we can put that much weight on you. I have a couple like really heavy lifters where I'm like, I don't know if we can put that much weight on this bar right now because our bars aren't rated for that right now. But yeah, like we have to like face that.
Yeah.
And allow the brain to kind of say like, we're okay in this position.
Yeah.
And at your weakest position, whether at the bottom of the squat, at the top of the deadlift, at the bottom of a bench press, on the catch of a snatch, like those things, we have to put you through that.
Yeah.
So the body can adapt, right? If we don't have specific stresses at those places, then we're kind of missing some of the point of this rehab.
Yeah, absolutely. I mean, do you find that they're receptive to that in the sense of, because I know that sometimes patients will want to just go out and do it.
I usually would have to like, I bring up like the timelines of injuries and everything like that, and then like why they got hurt at that spot and why we can't start there yet. Because at least if they're competitive, they understand this thought. You have to earn it, right? Yeah. You have to earn the right to go do that, right? With that being said, a lot of them can be very receptive to those things, but I hate saying that I don't bring it up right off the bat because I already know what they're going to do.
Yeah.
As in like, oh, I'm pain free right now.
Oh, better.
Right off of the table.
Yeah.
Very true. I'm expecting by the end of the day, you're probably going to feel it again just because that's kind of how your body compensates throughout motion, especially if it's been pain for a long time.
Yeah.
So I'm not going to say, yeah, go out and deadlift right now.
Yeah.
Probably not, right? I might pull you back for like a day or two, and then we introduce some things at specific parameters. But I'm never just going to say,
all right, go
do
ahead.
that.
Yeah.
Yep, go ahead, hit it. Unless you've earned it, right? So some of the rehab that I'll do for someone with a squat, you're going to get this gold nugget just because my brain's already going there. Yeah, if it hurt coming out of the squat, guess where we're going to have to start one of these days.
Yeah.
Pause at the bottom, and you're going to have to learn to love it.
Yeah.
Yeah, you've seen me do it myself too. It's hard.
Oh yeah.
Yeah, and you saw me almost die. Sorry, Mom, if you're watching this.
Whoa, that step didn't look correct.
Yeah. The best part is I laughed on the way up. I was like, yeah, that was close. That was real close. But yeah, we have to like own those positions that we
Yeah.
actually got hurt in,
Yeah.
because a lot of times if it's something that was in that motion, you were just weak right there.
Yeah.
Everything else was great, but at that specific time, maybe your pattern of bracing or your overall strength of that position was not good. So guess where we have to work?
Yeah.
Right there.
And I think that goes back to that kind of example you brought up with people who get in car accidents and they need to get back in the car to drive. You know, it's always you always are fearful of that return to whatever it was that caused the issue, but it's always going to be something that you have to almost face, like you said, to earn it, to be able to understand that you A, can get over it, and B, you can get through it because you're strong enough now.
Yeah, and that's really, to oversimplify what we do in the office, is that like, although yes, we're dealing with injuries, we're actually dealing a lot with hesitation to get back to whatever we want to do.
Yeah.
Right? So in some ways, I'm not saying we're licensed therapists, but we are licensed chiropractic and physical therapists.
We're homeboy therapists.
Homeboy therapists,
is what you would call it, I think.
Yeah. Yeah. It's, well, you know what's funny about that is that sometimes the patient will come in, they won't even sit in the chair, right? They'll just go straight on the table, face up, on the pillow, start talking. I was like,
all right, okay. There we go.
I technically have a
There it is. Yeah, exactly. We'll just get that right out of the way.
Yeah, it's like no eye contact with me at all when they're walking in, just on the table face up. And they're just talking. I'm like, I guess I'm just typing everything else.
Just here to listen.
Then I have to ask the same question that the therapist asks is, how does that make you feel?
Yeah, exactly.
And they're aiming for something else. I'm aiming for just like, okay, what hurt still? But yeah.
Like
Anyways,
that.
we're starting tangent a little bit.
Yeah,
here.
just a little. That's right.
But yeah,
That's good.
anything else to add here? I feel like
No, that was good. No, I think that we covered a really good aspect that has been, I think, in a lot of my treatment throughout kind of my career of understanding how that aspect can get missed and unaddressed. And I think sometimes patients don't even necessarily believe that that's addressable, right? And so I think that doing it the way you kind of explained it, by having to get into the position that caused the injury, is almost a form of other type of therapy for them.
Exposure therapy.
Yeah, there it is. So yeah, no, I think that was good, man.
Yeah, just to kind of put a bow on it, if you like Spark Notes, like I want Spark Notes, or the practical application is like, one, yeah, it's okay to kind of understand that there's fear with some of this. It's not okay to kind of just sit there in the fear that we can't get back to whatever you want.
Yeah, like don't let the fear rule you, right?
100%.
Control it and don't let it control you.
We didn't even talk about like the biological things that happen with fear, like high cortisol, which doesn't allow the muscle tissue to actually like truly heal. So in some ways, you worrying about it isn't helping.
Yeah, the hormonal aspect for sure.
There's so much more we can go off of that, but I'm going to be 100% honest. I'm not great with that part of it. I'm still learning all the small things. I shouldn't say still learning. I'm relearning some of the small things because I'm not sure about how you thought about those parts of the classes. You're like, I don't need to pay attention too much to that. Now that I'm here, I'm like, oh, I should have paid attention a little bit more, right? So I'm reviewing some of the notes. But all of this to say, like, how you think about your pain and how you address those issues on the emotional side does play a factor of it.
Yeah,
and
most definitely.
We recognize that and we understand that. But at the same time, we're going to handhold you through it until we can push you off the ledge and say, go fly.
Yep.
Right?
Absolutely, 100%. Yeah.
Or swim, because we're shark. I mean, we're not a bird.
Yes.
And, well, whatever you want to call it at this point.
Or run.
Right?
Right.
Or lift, whatever you want to call it.
Exactly.
I don't think we have anything else to add on that
No,
one.
I think that's good, man.
Yeah, well, it's a shorter one, but short and sweet.
Yep.
If you like what we're doing, go ahead, like and subscribe. Send this to a friend.
Yeah, comment below. Let us know what you think.
Yeah, and then
that'd be great.
You could also just give us topics to talk about too, because
Ooh, we love that.
that's always fun.
Because we're definitely scratching our heads sometimes around the office, wondering what we're going to talk about.
Yeah, like
ultimately we figure something out, but still,
I think the
it
biggest
helps.
thing that I love about you and Doc T and Alvin is that we just don't want to make things up.
No, I mean,
well,
obviously we get called out for it if we were making it up.
Like we're just talking about what we've
we're just-
experienced here at the office and like what we ran through.
Yeah.
We'll talk about some sports. Well, we're not really a sports podcast, you know. Like
No.
we can.
No,
Although
that's
if you
not the
want that.
reason.
Unless you want us to like live stream our draft of fantasy football, that could be kind of fun.
Yeah, but then we'd have to.
Don't worry about it. I'll figure it out. I'll figure it out.
Yeah.
I'll just have to have a cuss button.
Yeah, exactly. There it is. Cha-ching.
Yep, just every single time. Or that podcast won't come out in a while. So I'll sit there and edit all of it.
Exactly.
All right.
That'd be good.
Anyways, guys, it was fun checking on this topic.
Yeah,
and,
definitely.
The SHARC Doc. Yeah, no, it's Saturday. Yeah, we
Nice.
normally film it on different days. But
Yeah, it's okay.
it's a fun one.
Yeah.
Anyways, with SHARC Doc Talk, this is David.
Yep. PT Nandi.
And we're out.
Out.